Thank you for joining us for this on-demand webinar, Normal Wrist Anatomy and Sonographic Protocol, presented by Sarah Baker. Sarah Baker is the Clinical Education Coordinator for the University of Wisconsin Hospital and Clinic's School of Diagnostic Medical Sonography. Sarah has been a registered diagnostic medical sonographer and registered vascular technologist for 13 years, working directly in the clinical environment for 5 years, and then working in the education sector for the past 8 years. She also has the privilege of still working in the clinical environment on occasion to utilize her musculoskeletal sonography skills. Sarah has an extensive adult education, teaching, and coordinating experience, along with understanding a vast array of web-based learning management systems, LMS, and social media for the use of educational purposes. During her time as an educator, Sarah has found a great desire and passion for education and technology. She currently teaches undergraduate students pursuing a Bachelor of Science degree in biomedical sciences with a submajor in diagnostic medical sonography. She also teaches residents and medical students certain courses and laboratory classes in how to perform sonography. The sonography specialties that she currently teaches include abdomen, vascular, obstetrics, gynecology, pediatric neurosonography, and musculoskeletal.
My name is Sarah Baker, and I am the Clinical Education Coordinator for the General Vascular Sonography students at the University of Wisconsin Hospital and Clinic's School of Diagnostic Medical Sonography. Today I'll be going over with everyone the normal wrist anatomy as well as the sonographic protocol to evaluate the wrist. During this lecture, I'll be discussing transducer selection to perform a wrist exam as well as image orientation on the screen. I'll then be discussing the indications for performing a wrist sonogram, followed by identifying the anatomy in the wrist and what is seen on both the dorsal and the volar aspects. I'll then be discussing what should be interrogated with the wrist sonographic protocol, as well as the patient positioning in order to see these anatomical structures in the wrist. So let's get started. When performing a wrist ultrasound examination, we'll want to be using a linear array transducer. As we all know, linear array transducers are high-resolution probes with a rectangular footprint, with an excellent field of view when trying to image a wider area. The frequency ranges can be anywhere between 7 to 18 megahertz, and the various uses for linear probes include small parts or superficial structures, vascular structures, but most, if not all, superficial musculoskeletal structures will be evaluated with a linear array transducer. For the wrist in particular, you may be also utilizing the hockey stick probe. The reason for this is that the hockey stick has a little bit of a smaller footprint, and the wrist itself is not a very large area to be evaluating. So to see some of these areas, meaning the tendons, maybe in the dorsal compartments, we may want to use a hockey stick probe to get around the wrist and to see these structures. You may find, though, that the traditional linear transducer that we will be using too is very beneficial because it has a little bit different image resolution. The hockey stick probe is very high resolution, so it can almost appear a bit pixely, for lack of a better term, and so the higher resolution, just traditional linear transducer will be even more beneficial, possibly depending on how the resolution appears on your screen. Now into image orientation. As we know, our notch is our indicator of how the probe is positioned. I'm going to go over the typical or traditional way that we would be looking at ultrasound images with the notch and how it's positioned in the longitudinal and transverse view, and then go over the caveats and when we're scanning the wrist. In the long axis, typically our notch is going to be pointing towards the patient's head. So what this means is that everything on the left-hand side of the image will be the proximal aspect, and everything on the right-hand side of the image will be on the distal aspect. In the wrist, that's pretty much true as well. The notch will be pointing typically towards the patient's head, but you may find that doctors or yourself may want to have the notch pointing towards the distal aspect or towards the fingers. And if that's the case, just know that the opposite will be true. When we get into transverse or short axis, in the traditional world of things, or most of the time, the notch is pointing towards the patient's right side. In the wrist, it's different. When you're scanning the patient is actually looking at you, and typically the wrist or wrists are going to be on a table, and you'll be scanning the wrist either in the volar or the dorsal aspects. With this being said, the notch may not be pointing towards the patient's right. It may be pointing towards the patient's medial or lateral side, depending on if you're evaluating the right or left wrist or the dorsal or volar aspect. The take-home point with this slide is just know where your notch is positioned and what anatomy is underneath your probe, meaning bony anatomy, tendon or ligament anatomy when you're looking at things, and making sure that you communicate appropriately with your radiologist or interpreting physician about what it is that you're seeing and how you are oriented. Here's an example of longitudinal orientation in what we call the traditional sense, where the notch is pointing up towards the patient's head or more proximal. So the anatomy we're going to be seeing here is the radius, the lunate, and the capitate bone, with the radiocarpal joint and the midcarpal joint here. So proximal to distal. Again, here's a caveat. So this is in longitudinal. Again, not all sonographers or radiologists will prefer orientation as indicated in the slide prior. So just make sure you know where your notch is located and what structures are proximal or distal, medial or lateral, anterior posterior, just so you are aware and you can communicate that effectively to your physician. So in this image here, you can see that the notch was now pointing towards the distal aspect. So now distal is on the left-hand side, proximal structures are on the right. Moving on now to indications as to why you may be asked to do a wrist sonogram. In pediatrics, you may be asked to look at patients for pain or injury, swelling of the wrist, mass or cyst, in particular a ganglion cyst, or for juvenile idiopathic arthritis, or JIA. In adults, we may be asked to look at patients that are presenting with early arthritis, tendon involvement, carpal tunnel syndrome, wrist pain. An example of wrist pain would be de Quervain's tenosynovitis, ligament tears. We may be asked to assess for soft tissue masses, and we may also be asked for looking at patients in therapy monitoring for chronic arthritis. Next is a wrist protocol kind of template. You may be asked to just perform either dorsal or ventral wrist, depending on the symptoms. Your institution may ask you to do the entire wrist, and if that's the case, you'll be doing both aspects. In the institution where I am at, when we're asked to do a wrist sonogram, it'll either be to do with the dorsal side or the ventral side, depending on symptoms. On the dorsal side, you'll be asked to look at the distal radial ulnar joint. You may be asked to evaluate the radiocarpal and midcarpal joints, the triangular fibrocartilage, which is near compartment 6, which we'll get to what that is in a moment. We'll then be asked to evaluate the extensor tendon compartments. So compartments 1 through 6, there's a total of 6 different compartments with tendons in each of those compartments. And in compartment 6, there's a tendon that's an acronym called ECU, which we'll get to what that acronym stands for in a moment. But we may be asked to do a subluxation test of that tendon in that compartment. We'll be asked to look at the scapholunate and lunotriquetral ligaments. And we may be asked to evaluate other joints based on clinical symptoms, and these can include the carpometacarpal, the metacarpal phalangeal, the proximal interphalangeal, and distal interphalangeal joints. On the ventral or the volar side, we'll be asked to evaluate the flexor tendons, the median nerve that's traversing in the carpal tunnel, as well as Guyon's canal, which we'll be looking at the ulnar nerve. Before we go into the protocol in its entirety, I thought it would be an important time to go over the wrist and hand terminology, bony anatomy, ligaments, and joints. And then we'll get into more of the tendons and compartments on the dorsal side, and then the flexor tendons on the volar side. So dorsal side, what does that mean? Well, it means that the palm will be down, as we can see illustrated here in this photograph. If we think about it, when we have our hand on the dorsal aspect, our fingers can extend. Why I'm telling you this is because the tendons on the dorsal side that we'll be evaluating are known as the extensor tendons. If you kind of can look at how our anatomy lays, the names can kind of help us make sense of things. So this will be, again, fingers extend. These will be our extensor tendons that we'll be looking at. As opposed to the volar side, that means that the palm is up, as illustrated here in this photograph, And again, if you think about it, when your hand is in the palm up position, and if we took our fingers, they flex. So on this side, when we look at the volar aspect of the wrist, we'll be looking at the flexor tendons. Moving on now to the wrist and hand bones. I have an illustration here of the volar or palm up aspect of the hand, and it will be important as to why I'm telling you this in just a moment. But going over the carpal bones, there are two rows of carpal bones. There's a proximal row and a distal row. In the proximal row, as we move from lateral to medial, we'll have the scaphoid, the lunate, the triquetrum, and the pisiform. The pisiform will only be able to see on the volar aspect. And if you actually were to turn your palm up right now as we speak, you'll be able to feel that pisiform bone that's on the more medial aspect. If you find your pinky, go all the way down to your wrist, that little bony aspect there is your pisiform. The distal rows are here, and these include the trapezium, the trapezoid, the capitate, and the hamate. Those are the 8 bones, and they can be kind of hard to remember. So when you're doing a wrist protocol, I would have these bones kind of handy for you as a little cheat sheet, just so it makes it easier. Some others have recommended using a mnemonic to attempt to help make sense of the bones, and they use the first letter of each of the bones to make a different sentence. And you can see there's different ones here that I've listed that you can use at your leisure if you find them helpful. This is another diagram here going over the bones. I just wanted to again review them here. So on the dorsal aspect, the proximal row will include the scaphoid, the lunate, the triquetrum. You can see that the pisiform is illustrated here in the diagram, but again, remember that when you're scanning, you won't be seeing the pisiform in the dorsal aspect. And then in the distal row, we have the trapezium, the trapezoid, the capitate, and the hamate. When we turn our palm up on the volar aspect, again, the proximal bones will be the scaphoid, the lunate, the triquetrum. Now we'll be able to see the pisiform, the trapezium, trapezoid, capitate, and hamate. Moving on now to wrist joints. There are several wrist joints that we can, or I should say joints that we can look at in the wrist and in the hand. For the protocol, most likely you'll be looking at the distal radial ulnar joint, the radiocarpal, and the midcarpal, but I did include the others here just so you're aware of what they are for anatomy purposes. So the distal radial ulnar joint is going to be located here. And when we get to this in the protocol, how we'll be seeing this is in the transverse view because we need to see both radius and ulna in the same picture. The radiocarpal joint is the joint in between the radius and the proximal carpal row of bones. So we'll typically be placing the probe now in longitudinal, looking between the radius, kind of the scaphoid, or the lunate, depending on where it is that you're looking. And then the midcarpal joint is in between the proximal and the distal rows of carpal bones. So anywhere along here would be indicated of the midcarpal joint. You may be asked to look at other joints depending on clinical signs and symptoms of the patient, and if so, these are what the other joints are. The carpometacarpal joints are located here between the metacarpal bones and the carpal bones of the wrist. You may also see the acronym known as TMC for thumb metacarpal, which is right here. We then have the metacarpal phalangeal, which separates the metacarpal from the phalanges here. You can see that all here. And then in digits 2 through 5, we'll see the proximal interphalangeal joints and the distal interphalangeal joints. So to show you some of these joints more in view here, the radial ulnar joint, like I was saying, will be best seen in the transverse view because we need to see both the radius and the ulna and then the joint space that's in between. Remember that joint spaces are just spaces between bones, and usually the joint space is helpful as far as trying to find them because they're named after the bones that they are connecting, or the two bones involved. So you can see here that here's the radius, here's the ulna, the joint space is in between the two. The radiocarpal joint is located between the distal radius and the carpal bones. So in this image here, the sonographer has the probe positioned in the longitudinal aspect with the notch facing more proximal. And so we can see the radius, the lunate, and the capitate bones right here. So the radiocarpal is only between the distal radius and the carpal bones, so that would be indicative of this area here. And then I'm getting ahead of myself on one slide, but you can see the mid-carpal joint is located here between the lunate and the capitate. And in this diagram, it shows it nicely too. So the probe is positioned in this area here, again between the radius and the lunate, right in this region. If fluid is located here, you'll be able to most likely see it extending across this kind of joint space area, so you'll want to evaluate the fluid in its entirety. Then the mid-carpal joint is located between the proximal and distal rows of the carpal bones. Again, the same image that was on the last slide. This is showing the mid-carpal joint between the lunate and the capitate. This is just a diagram showing you here an illustration of the radius, the lunate, and the capitate, and how the radiocarpal joint is in between the lunate and the radius, and the mid-carpals between the capitate and the lunate. Now, you could move over onto a different area of the carpal bones. This is just showing you one slice of where the radiocarpal and the mid-carpal joint are located. Some wrist ligaments that we'll be looking at, and again we'll be talking about these in a little bit more detail in a few more slides ahead. Wrist ligaments, remember ligaments in general, connect bone to bone. This is different than tendons. Tendons connect muscle to bone. But with the wrist ligaments, again, sort of like how joints are named, ligaments are nice too because the names indicate the bones that they're connecting. So the scapholunate ligament, this is going to be in between the scaphoid and the lunate bones. We can see this mainly on the dorsal aspect, but there is a volar component too. We can see this here. Here's the scaphoid, the lunate. We can see the scapholunate ligament between the two. And then the lunotriquetral, this would be between the lunate and the triquetral bones, and we can see that the lunotriquetral ligament is in between the two. A cartilage structure we'll be looking at in compartment 6 is the triangular fibrocartilage complex. This is located in the ulnocarpal space near compartment 6, and how we look at this is in longitudinal. So this is ECU. This is going to be in compartment 6. And we'll be getting to what that tendon is in just a moment. But in order to see the triangular fibrocartilage complex, you'll have to be longitudinal on the ECU, and the ECU is the extensor carpi ulnaris. And then right below the ECU, we'll see this triangular fibrocartilage between the triquetrum and the ulna styloid. So we'll be right in this region right here. This is just another image showing you here the triquetrum, the ulna, the extensor carpi ulnaris, and then the triangular fibrocartilage. Okay, so now moving on to anatomy on the dorsal side, and we're going to get into the protocol on the dorsal side of the wrist. So again, remember that on the dorsal side, our fingers extend. So we have extensor tendons. Remember that tendons attach muscle to bone. On the dorsal aspect of the wrist, there are 6 compartments that these tendons are divided into. 1 through 6, 1 starting more on the radial side and 6 ending on the ulnar side. Each compartment has a single synovial sheath over the tendons themselves, as you can see here. And I've indicated here Lister's tubercle, and in this diagram it's indicated by the asterisk. It's a bony protuberance that's found between the 2nd and the 3rd compartments, but it's really an invaluable landmark to help you get oriented in general. So if I get lost when I'm looking at the dorsal compartments of the wrist, I'll try to go back to the radius in transverse, look for this Lister's tubercle, and then that helps me get my bearings on, okay, I see compartment 2, compartment 3, and now I can move on to 4, 5, 6, and it can really be a helpful landmark for you. Each tendon should be evaluated both in longitudinal and in transverse, and utilizing color and or power Doppler depending on what is indicated at your institution for any kind of hyperemic or inflammation changes. So this is sort of a busy slide with diagrams, but this is showing again compartments 1 through 6, and I really liked this table that it was referenced from Jacobson because it goes through where these tendons insert, and I think that's a very important thing to know when we're looking at tendons, to know where they're going to. So we'll be going over these kind of in their entirety, but it's a very nice diagram and table for you to reference when you're trying to evaluate these dorsal compartment tendons. So we're going to go through each of these compartments. The first compartment is the most radial, and you're going to be having your patient's thumb pointing up towards the ceiling. The two tendons in here are the abductor pollicis longus and the extensor pollicis brevis. They stack on top of each other here in this diagram, but when we're scanning them on ultrasound, they just lay side by side. So when we're looking at them here, the APL is going to be more towards the thumb. The EPB is going to be located more towards the second compartment. So what I kind of do when I'm trying to figure this out is I look at the extensor pollicis brevis as it's next to the second compartment. When we get to second compartment, brevis is next to Lister's tubercle. So it seems like the brevis is going more on the ulnar side of things, if that helps. So here's the first compartment in longitudinal. So we'll be looking at it both in transverse and in longitudinal. And in transverse, we'll be looking at it from proximal to as far distal as we can see it. And then the same in longitudinal, trying to evaluate both tendons in their entirety and then trying to see how far they can extend or where they insert. The extensor pollicis brevis, or the EPB, will be inserting onto the proximal phalanx of the thumb. Moving on now to the second compartment, this is the extensor carpi radialis longus and the extensor carpi radialis brevis. Again, brevis is closest to Lister's tubercle, so we've got longus and brevis right here. So we'll want to look at these in transverse, again, from proximal to distal. And in this image here, it's nice they show you where Lister's tubercle here is on the radius. And again, looking at these tendons in longitudinal, from proximal to distal, or as far distal as we can see it. The extensor carpi radialis longus is going to insert on the base of the second metacarpal bone, whereas the extensor carpi longus brevis is going to insert on the base of the third metacarpal. And this is just showing you here the comparison between compartment 1 and compartment 2. Showing you here it's moving more from the radial aspect to the ulnar aspect. We can see that the brevis tendons here, the EPB and the ECRB, are located more on the ulnar side of things. Moving on now to the third compartment. So remember when we said that Lister's tubercle is going to be on the radius, this divides the compartment 2, which is the ECRB, from the EPL, or the extensor pollicis longus. Again, Lister's tubercle, yes, helps divide compartments 2 from compartment 3, but again, it's a very invaluable landmark when you're trying to assess where you're at in the dorsal compartments. Again, EPL, you're going to be looking at that from proximal to distal and transverse, as well as in longitudinal. The extensor pollicis longus, or the EPL, this is going to actually insert onto the distal phalanx of the thumb. If you were to be following this more distal, you'll see that as we move down more distal, that this EPL is going to go over and move over the top over the compartment 2 to try to traverse to get over to the thumb. And again, here it is in longitudinal. And this is showing compartments 2 from 3. So again, here's compartment 2, Lister's tubercle, and then we have EPL right here. And moving on to the fourth compartment, these are the tendons of the extensor digitorum, and these are going to be going to the second through the fifth fingers. If you can kind of see this here, it's a sort of a large conglomerate of tendons, and as you move more distal, you'll see that they splay out as they're going to their appropriate digits. Some patients may have an extensor indicis proprius tendon. This is absent or rudimentary in approximately 40% of individuals, but it can be there. Just so you're aware of that. These tendons, like I said, are going to be going onto the second, will be going over the second through the fifth fingers, and that's going to be how they splay on out. And we'll try to evaluate these in longitudinal. It can be a little tricky since there's so many tendons in this compartment, but try your best in looking at them from proximal to distal. Then in the fifth compartment, we have the extensor digiti minimi, or it's known as the extensor digiti quinti proprius, or EDQ, depending on which literature you read. But this is going to be located here in compartment 5. It's a small tendon here that we can see on this side as well. Try to follow that again, proximal to distal and transverse and in longitudinal. And this will be going over to the phalanx of the 5th digit and following it in longitudinal there. This is comparing compartment 4 to compartment 5. Again, you can see here that this is a larger compartment here in the 4th compartment. And then compartment 5 right here is just a very small little tendon right here. Then moving into the 6th compartment, this is the most ulnar, so you may have to rotate your patient's wrist up. So the pinky side is up, pointing up towards the ceiling. This is known as the extensor carpi ulnaris, and this is going to be located in a little groove here on the ulna. You can see it here. It's an actual pretty prominent tendon that you should be able to see if the patient is positioned appropriately. Again, we'll want to look at it from proximal to distal and transverse, and this is going to insert on the base of the 5th metacarpal. This is looking at this here. We can see that there's a sheath that runs over top of it, and we're going to go through the importance of what that is in just a moment. This is evaluating it in longitudinal. And then looking at a dynamic evaluation of the 6th compartment, we may be asked to do a dynamic assessment to evaluate for subluxation. In order to do that, we'll have to try to have the patient, while you're scanning, move from pronation to supination or supination to pronation. And the point with that is to see if the ECU is going to stay put in this little groove in the ulna, or if it slips out of its sheath and moves out of its groove and therefore subluxing. We'll want to be looking at that and evaluating for that. And this is just showing you here an image if you were asked to look more at the extensor tendons in the digits going from 1 to 5. This particular image and photograph is showing the extensor tendon digit in the 2nd metacarpal phalangeal joint in longitudinal. Just showing you that there. You may be asked to look at the fingers. Now moving again into the joints, we talked about them a little bit a while ago, just as a brief overview. But in looking at the distal radial ulnar joint, you're going to want to try to find and be in the region of compartments 4 and 5. Move the probe to be out of the carpal bones and beyond the distal radius and ulna in transverse, and you should be able to see the distal radial ulnar joint. So this is showing you here compartments 4, compartments 5. Here's the radius, here's the ulna, and then we're right here in this joint space looking for fluid. Again, radius, ulna, joint space. In this one, they had the notch flipped the other way, but here's the ulna and the radius, and here's the distal radial ulnar joint, followed by compartments 4 and 5. The radiocarpal and midcarpal joints, placing the probe in short axis, you may want to find compartment 5 and then turn in longitudinal to try to find the radius, the lunate capitate. You'll see the radiocarpal joint here between the lunate and the radius, and then the midcarpal joint between the capitate and the lunate. And again, if there's fluid, you should be able to kind of see that fluid traverse throughout the joint spaces. This is just another diagram and ultrasound image to help illustrate this as well. Moving from proximal to distal, radius, lunate, capitate, metacarpal here. We have the radiocarpal joint, the midcarpal joint, and the carpal metacarpal joint. And then trying to use the same arrows here on the ultrasound image. Here's that radiocarpal joint, the midcarpal joint, and the carpal metacarpal joint right here. Then looking at our ligaments, the scapholunate ligament during dorsal evaluation. In short axis, try to identify compartments 2 through 5, identifying the radiocarpal joint. The scapholunate ligament is going to be seen between the scaphoid and the lunate bones. You may find that if you do a little bit of an ulnar deviation, meaning that your hand is deviated more towards the ulnar side, it may help pull that ligament out better for you and visualize it better. So here's the scaphoid, here's the lunate. Here's compartment 2. We're not really seeing compartment 3 in this view, but we can see compartment 4, compartment 5. Here's scaphoid, here's lunate, here's that ligament. And on this side, the notch is just flipped. We can see the scaphoid, the lunate, and then here's the scapholunate ligament here. Then the lunotriquetral ligament. Locate in short axis compartment 5. Try to identify the lunate and the triquetrum bones, and then this ligament will be seen in between the two. So here's compartment 5 right here, here's compartment 4 and compartment 6. Here's triquetrum, here's lunate, and then our lunotriquetral ligament is right here. Again, radial side of the wrist, ulnar side of the wrist. You may be asked to see the ulnar collateral ligament. And even though it's called ulnar, it's not near the pinky, it's actually on the thumb. The reason why it's called ulnar collateral ligament is because it lives on the ulnar side of the thumb. It connects the metacarpal and the proximal phalanx of the thumb, and we can see this ligament right in here. And you'd have the probe position like so to try to see that. So that wraps up the dorsal side. Moving now onto the volar side, so now the palm will be up. Remember, our fingers flex, so we'll be looking at our flexor tendons in this view. So on the volar aspect of the wrist, there are a total of 9 flexor tendons that enter the carpal tunnel to reach into the fingers. There are 4 tendons from the flexor digitorum superficialis, indicated here by the S, and on this diagram here, the more superficial layer will be the superficialis flexor tendons. And then there's 4 tendons that form the flexor digitorum profundus, or the deeper row of the flexor digitorum tendons. Again, here where everything is labeled P. We also have the flexor pollicis longus tendon, and this will be going towards the thumb. And this is also located within the carpal tunnel. It's located here, and it's located here. Then we have 2 primary flexors that are outside of the carpal tunnel, and those are the flexor carpi radialis, which lives on the radial side of the wrist, and the flexor carpi ulnaris, which lives on the ulnar side of the wrist. The carpal tunnel itself is sheathed, and we'll go over this in a moment, by what we call the flexor retinaculum or the transverse carpal ligament, whichever literature you read. So this is showing you here a diagram, an ultrasound image of the wrist tendons, both in the carpal tunnel and outside of it. So within the carpal tunnel here, you can see the more profundal layer here and the superficial layer here, the flexor tendons, the flexor pollicis longus here, that's going to go to the thumb, the median nerve that lives in the carpal tunnel. This is that flexor retinaculum, or the transverse carpal ligament. And then outside of the carpal tunnel, we're going to have the flexor carpi radialis. This diagram does not show us the flexor carpi ulnaris, but we'll get to that in a little bit. But the ulnar nerve and then the ulnar artery are right here. This is on the radial side, this is on the ulnar side. And now we are able to see the pisiform because we're having our wrist positioned on the volar aspect. So scaphoid, pisiform. If we wanted to see our other carpal bones, we're seeing the lunate, the triquetrum. We can see the flexor carpi radialis, the flexor pollicis longus. This conglomerate here, they just labeled as the long flexor tendons, and in this area are the superficial and the profundal layers. The median nerve, the ulnar nerve are all located here. Another ultrasound image, just to reiterate the same points that we just stated, or that I just stated in the slide prior. Again, you can see the scaphoid here. This is the flexor carpi radialis. You can see the median nerve, the superficial layer, and the deep. And then showing this ultrasound image here as well, this is the flexor pollicis longus in the thumb, median nerve, all of our flexor tendons housed within the carpal tunnel. The flexor carpi radialis is going to be outside of that. Here's our pisiform and our ulnar nerve, also outside of the carpal tunnel. And this is more in the distal aspect of the wrist on the volar side. This is now moving into the trapezium and the hamate bones. We're still able to see the flexor pollicis longus, the median nerve, and then our flexor tendons. The flexor tendons, as they move into the hand, into the wrist, and into the fingers, I just wanted to show this diagram here to show where the flexor digitorum superficialis and profundus went to. And in the fingers themselves, you can see the superficial layer is on the superficial aspect of the fingers on the bone, and then it wraps around the bones of the kind of distal phalanx here. Whereas the flexor digitorum profundus is going to be deeper to the superficial layer. Now going into the primary tendons of the wrist, or the primary flexor tendons, this is going to be the flexor carpi radialis and the flexor carpi ulnaris. These are going to both course outside of the carpal tunnel, and they can be readily palpable. The flexor carpi radialis is going to originate midway between the elbow and the wrist, and we can see it nicely here in this diagram. It's invested by its own synovial sheath, and the tendon itself is going to insert onto the palmar aspect of the base of the second metacarpal, as we can see right here. The flexor carpi ulnaris is the only tendon in the wrist not invested by a synovial sheath. It courses on the ulnar side of the wrist, and it's housing the pisiform. It's going to insert on the hook of the hamate bone in the fifth metacarpal, and it's a landmark for the ulnar artery and nerve. The ulnar artery and nerve are going to be more radial to the flexor carpi ulnaris tendon. So this is looking at the flexor carpi radialis tendon, both in longitudinal and in transverse. So we can see that there going to that second metacarpal. We can see it here in transverse. And then the flexor carpi ulnaris, this is going in longitudinal here. And then in transverse, this is showing you here the flexor carpi ulnaris, the ulnar nerve, and the ulnar artery, and how the ulnar nerve and the ulnar artery are more radial in comparison to the tendon. The flexor pollicis longus, or the FPL, I wanted to show this too. So this one goes again to the thumb, whereas the other flexor tendons, the superficial and profundal layers, those go to the fingers themselves, or digits 2 through 5. The flexor pollicis longus is going to go to the thumb, and this is how we would view it here. The transducer would be positioned like so, and we would find the tendon here on the thumb. You may be asked to look at the volar plates within the fingers themselves to assess if they're intact. They look very similar to the plantar plates that are in the feet, and again being assessed for the same reasons, for to see if they're intact. This is just showing you here what they look like on ultrasound and where they're located if you were to put the probe, and what they look like on a diagram. And this is showing you again another image of the volar plates here. Here's proximal, middle, and distal phalanx. You'll see the volar plates are located in both of these locations here. And then showing you where the superficial and profundal flexor tendons are located in the fingers. You can see that the superficial tendon is on the superficial aspect, and the profunda is going to be deep. Moving on now to wrists, or nerves in the carpal tunnel. And the nerves will have a fascicular appearance, and what that means is that they have a honeycomb appearance and short axis. So we'll be looking at the median nerve in the carpal tunnel. The carpal tunnel is the passageway from the wrist to the hand, and it's located on the volar, or the anterior aspect of the wrist, and it's made of tendons, ligaments, and bones. The median nerve passes through this tendon, and this is what we're going to be assessing. Why we want to look at the median nerve in the carpal tunnel is to assess to see if there's anything in the wrist that's compressing on the median nerve, or if the median nerve is narrowed for whatever reason from point A to point B. So you'll be doing diameter measurements of the median nerve from side A to side B, so symptomatic to asymptomatic side, and you'll also be doing wrist diameter measurements from proximal to distal on the affected side. The median nerve, in a little more detail, is distal in the forearm. It courses between the flexor digitorum profundus and flexor digitorum superficialis muscles. And then inside the tunnel, it runs superficial to the flexor pollicis longus and the flexor digitorum superficialis tendons. And it's covered by a strong fibrous band. And that fibrous band, as we said before, is that transverse carpal ligament, also known as the flexor retinaculum. So you can see this is that median nerve right here, located within the carpal tunnel. Okay, so this is again showing you the same image here, where we have the nice transverse carpal ligament, or flexor retinaculum here. Median nerve is going to be superficial to the superficial flexor nerves here, and also superficial to the flexor pollicis longus tendon. And here we're showing the same thing in the ultrasound image. This is moving now more distal in the carpal tunnel, so now we have the trapezium and the hamate bones here, and we still see our flexor tendons within the carpal tunnel, and we have our flexor pollicis longus tendon here for the thumb, and here's our median nerve. So like I was saying in the slide prior, we would take diameter measurements at the proximal level and distal level of that median nerve to see if there's any size difference between those two spots, and then we'll also take a diameter measurement of the contralateral side that's asymptomatic, if it's asymptomatic, to see if there's any difference in size there as well. Another nerve that's going to be in the wrist is the ulnar nerve, and distal in the forearm, it lays on the radial side of the flexor carpi ulnaris and on the ulnar side of the ulnar artery. It gives off two small branches on the palmar and dorsal cutaneous aspects and goes into branches that are named appropriately. You won't most likely be able to see those two different branches. Distally, it is superficial to the transverse carpal ligament in the Guyon tunnel or canal, and it's superficial and on the ulnar side relative to the carpal tunnel. The ulnar nerve will bifurcate within the Guyon tunnel, and the two terminal divisions will be the superficial sensory branch and the deep motor branch. So if we can see here on the diagrams, we can see the ulnar nerve is located here in yellow. As you can see, it is going to be more radial to the flexor carpi ulnaris tendon here, and it's more on the ulnar side compared to the ulnar artery. When we look at Guyon's canal or Guyon tunnel, whichever literature you read, you'll see that it's a 4 centimeter long depression between the pisiform bone and the hook of hamate, and it starts at the proximal end of the transverse carpal ligament. And it's going to end at the epineurotic arch of the hypothenar muscles containing the ulnar nerve. So you can see here the pisiform bone, the ulnar artery, the ulnar nerve is going to live in that space. And then we can see as we move a bit more distal, that hook of hamate, that ulnar nerve gets smaller, and we can still see the ulnar artery right here, and we can see that it splits within the canal. And then lastly is the radial nerve. In our protocol, we're not asked to look at the radial nerve for the wrist, but technically you can see it. It's more near compartment 1, more on the dorsal aspect, but given that it's a nerve, I thought I would still put it in this category. The radial nerve, we're going to be looking at it, if we see it in the wrist, is the cutaneous terminal branch. And distal in the forearm, it's going to be in between the extensor carpi radialis longus and the brachioradialis tendons, reaching to the subcutaneous tissues. Distally, it will pierce the fascia and overlie the anatomic snuff box and traverses the extensor tendons of the first compartment. So we can see it out in this region here if we were to be asked to look at it in the wrist. So in summary, the wrist and hand anatomy is complex, but the pertinent and common indications for performing a wrist sonographic exam are pretty straightforward. You mainly have to look on either the dorsal or volar aspects depending on your patient's symptoms and also depending on your institution's protocol. But if you can kind of compartmentalize the wrist into dorsal and ventral aspects, that can hopefully make things a little bit easier in trying to understand and really kind of almost memorize some of that anatomy too. I hope you found this helpful, and I thank you very much for your time and attention during this webinar.